All right, welcome everybody to this ERGNet ESPN educational webinar. My name is Max Liebau. I'm a pediatric nephrologist, and I'm speaking from my office in Cologne in Germany. It's my great pleasure to introduce today's speaker. Well, most of you will know anyway, Professor Nina Kneurs. Nina is currently the chair of the Department of Genetics at the University Medical Center in Groningen in the Netherlands. Nina received her MD and PhD from the Catholic University in Nijmegen. She was then trained and certified as a clinical geneticist at the Radboud University Medical Center in Nijmegen. She was chair of the Department of Genetics at the University Medical Center in Utrecht. She was the chair of the Dutch Society of Clinical Genetics and a member of the Dutch Health Council, among other recognitions and positions. Nina's major research effort focuses on the identification of genes for inherited renal disorders and on their pathophysiology. And she's a member of several European consortia on genetic renal disorders like urinomics, etc. Nina has been awarded a lot of prizes and awards, and we would spend too much time listing them all up. She's published almost 300 scientific papers, including manuscripts in Nature Genetics, Science, Lancet, and the New England Journal. And it's really a great pleasure to have you giving this lecture. Could you please, everyone, first mute yourself for the lecture. During the talk, you have the opportunity to ask questions in the question box. And now it's my great pleasure to hand over to Nina for the talk, When to Perform Genetic Testing in CATGUT and What to Test. Thank you.
Thank you very much, Max, for this very nice introduction, and also for giving me the opportunity today to talk about CATGUT and especially answer the question when to perform genetic testing and what to test. So I've nothing to disclose, and this gives you an outline of what I'll be talking about today. I'll give you a few words about the epidemiology and the disturbed nephrogenesis, which is assumed to be involved in CATGUT, and then quickly move over to the etiology, where of course the focus will be on the genetic factors. And then of course the purpose of today is to go to what molecular tools are available for CATGUT, and then finally answer this question, when should you perform genetic testing and what to test, and finally some take-home messages. So I'd like actually to start with a poll question, and this question is, would you answer for yourself the question, my background knowledge on the genetics of kidney disease in general and CATGUT in particular is low, moderate, high, or do you see yourself as an expert? And you see the question and you can submit it. You have about a minute to do that. I hope, Tanya, we can see the results of the poll. Well, nobody considers himself an expert, but I think it's quite nice to see that at least the half of you think that you are really have some knowledge of genetics and CATGUT, which is very nice. Thank you very much. Oh. So what we know about congenital anomalies of the kidney and urinary tract is that it's quite a frequent disorder. It's actually the most frequent developmental disorder in humans, with a frequency of 1 in 100 to 500 live births, and it accounts for approximately 20% of prenatally detected anomalies. It is the leading cause of kidney failure in children and accounts for an, I think, underestimated proportion of chronic kidney disease in adults. Here you see a picture of a very recent, very nice review of Harada et al. In pediatric nephrology, where you see that they have looked at the causes of CATGUT in 4 different cohorts. So it's a US cohort, an Australian a New Zealand cohort, the European era cohort, and a Japanese cohort. And actually you can say all over the cohorts, CATGUT is in these children indeed the most important cause of CKD. So this is worldwide the case. So what do we consider CATGUT? Here you see a picture of the different anomalies, a spectrum of the structural malformations that belong to CATGUT. So this can go for a mild disorder like the horseshoe kidney, but also uretero-pelvic junction obstruction, reflux, and duplex collecting systems towards more severe diseases such as renal agenesis and multicystic dysplastic kidney. Whether or not posterior urethral valves do or do not belong to CATGUT is still a matter of debate. Many consider it part of CATGUT, others think it is not. It's important to know that in a same individual, you can have the co-occurrence of different anomalies of the CATGUT spectrum. What CATGUT anomalies have in common is that it's due to disturbed embryonic kidney and urinary tract development. Many of you know how this development works. So at the 5th week, actually the uretag branch under the induction of the metanecroid mesenchyme begins to grow, and then the interaction between uretag butt and mesenchymes then leads to the further branching of the uretary branch, and finally also the mesenchymal to epithelial transition of this mesenchyme, and then finally growing out in the nephron patterning. You could simply say that defects in the uretaric bud outgrowth lead to kidney agenesis, whereas ectopic uretaric bud outgrowth leads to duplex collecting system, whereas later disruptions, for instance, in branching morphogenesis, could lead to kidney hypoplasia. CATGUT etiology is actually very complex. The hypothesis is that genes that are essential for kidney development are subject to environmental, genetic, and epigenetic modifications, which together disrupt their regulation and results in increased susceptibility to CATGUT. Today, I will be mainly talking about these genetic causes, but it's important for you to understand that also environmental causes, for instance, maternal health, for instance, diabetes, can give an increased risk for CATGUT, but it's also assumed that epigenetic causes, so those that actually are involved in gene expression regulation, could be involved in causing CATGUT. And as said, it's probably also an interaction between these different factors. So CATGUT is actually a disorder that is in between monogenic and complex etiology. And you see this picture here. So you have the clear Mendelian disorders where the disease is simply the direct effect of pathogenic variants. So these are the real monogenic disorders like autosomal dominant polycystic kidney disease, recessive polykidney disease, Bartter syndrome, and so forth. And on the other side, you have the real common diseases like cardiovascular diseases or diabetes, which is actually due to a combination of many genetic variants with very small effects combined with environmental and epigenetic influences. And CATGUT is actually in between those two. So a minority is really explained by single gene pathogenic variants, whereas the majority is explained by either an oligogenic or polygenic model together with environmental and probably also epigenetic influences. So looking at monogenic CATGUT, we could now say that about 10 to 15% of all cases are explained by single gene pathogenic variants. Most of them have a dominant inheritance, but we also know of recessive causes, X-linked causes, and there is rather a high frequency of de novo causes. And once this de novo mutation has occurred in a person, after that, it is then inherited, goes to further generations as a dominant disease. CATGUT, as you probably know, is sometimes and even maybe even not sometimes, but frequently part of a multi-organ syndrome. Examples are the renal coloboma syndrome caused by PAX2 mutations, or the bronchio-otorenal syndrome caused by AR1 or 6.1 pathogenic variants. Again, from this very nice recent review from CATGUT et al., you see this nice picture which actually demonstrates the main extrarenal manifestations that have been seen associated with monogenic CATGUT, and you could say that actually almost all organs can be involved. What is also very important to know is that among these monogenic cases, there are also cases explained by pathogenic copy number variants. And this is not only the case in syndromic cases, but also in non-syndromic cases. And I'll be coming back to that later. An important characteristic of monogenic CATGUT is that it's genetically very heterogeneous. At least 50 genes are involved, but probably just many more. And this, again, from this nice review from CATGUT et al., shows you a list of some of these genes. And it's important to recognize that PAX2, HNF1 beta, and AR1 are the most frequently involved genes. Recently, in a review we have published in NDT, we have given a more complete list of all the genes and associated phenotypes. So if you want to have a look at that, please do. It's also important that the story goes on. So very recently, a very nice paper by Munch et al. And Kidney International showed that in addition to Robo2, which we already knew that was involved in CATGUT, there is now also proof that biallelic pathogenic variants in Robo1 can lead to CATGUT, syndromic CATGUT, with the involvement, as you can see, of many other systems. Another important characteristic of monogenic CATGUT is that its expressivity is extremely variable. And this means that in individuals carrying pathogenic variants in the same gene, or even the same pathogenic variant, can have very different expression of the phenotype. So there is intra-individual variability, as already mentioned. There can be co-occurrence of different anomalies within the same individual. And in meta-analysis, it has been shown that about 1 in 3 cases with a unilateral kidney agenesis or multicystic dysplastic kidneys, there is reflux or uretero-pelvic junction obstruction on the contralateral side. It has also been shown that monozygotic twins, who of course have exactly the same genotype, can have discordant phenotypes. More importantly, there is also inter-individual variability. So we see within families, and there the patients have the same genotype, that there can be very different phenotypes among the different family members. And what is also important, there can be incomplete penetrance. So in this family, you see the different phenotypes in the different colors, but you can also see that the father here has a sister with CATGUT and 2 children with CATGUT, but he himself doesn't have CATGUT at all. And so he is a non-penetrant carrier of the mutation. And there are many examples of variable expressivity in literature. Here is a nice example of a family with a PAX2 mutation, where you can clearly see that many different family members have different phenotypes, and you can even see that there can be duplex kidneys in one patient, whereas there is kidney agenesis in a sibling. So again, showing this variable expressivity. As said, copy number variants are very important in syndromic and isolated CATGUT, and copy number variations are actually structural variations in the genome in the form of gains, so duplications or losses, deletions of DNA fragments. And in a very nice study published in a couple of years ago by Ali Garavi's group, by Sana Serci et al., they've performed a genome-wide analysis of copy number variants in a large cohort of more than 3,000 CATGUT patients, which had the full phenotypic CATGUT spectrum and a very large number of population-based controls. And in this study, they really found an increased burden of these large, rare exonic CNVs in CATGUT. And it's very nice to see that even if they excluded the syndromal cases, then still this increased burden remained, indicating again that also in isolated CATGUT, CNVs are important. In patients with the kidney anomalies, these were mostly exonic deletions, whereas in patients with reflux or urethral valves, there was mostly exonic duplications. They also showed, and this is nicely summarized again in this review by Kagan in pediatric nephrology, that 6 loci account for most of the CATGUT cases that are caused by CNVs. And here you can see, for instance, the locus 70q12, where the renal driver type, the renal phenotype driver gene is HNF1 beta, and the 22q11.2 locus where CRKL is the renal phenotype driver. And we know that, of course, of the velocardiofacial or DGeorge syndrome. Well, for clinical genetic testing, we all know that in recent years, this has completely changed by the coming of massively parallel sequencing, also known as next generation sequencing, where we moved from doing one test per gene to actually testing all involved genes. We can do this by disease-specific multi-gene panels, by whole exome sequencing, which involves all of the genes, or by whole genome sequencing, which involves the complete DNA. And this actually led to very rapid and cost-effective sequencing of large amounts of DNA. When we look to the possibilities for CATGUT, we could say that there are different possibilities, and I'll mention them, but I'll also mention what is mostly used now. So first of all, we can use a targeted phenotype-associated gene panel. So this is actually the sequencing of a specific pre-selected set of genes that are relevant to CATGUT. And the advantage of this is that because you really only look at these genes relevant to CATGUT, there is no chance that you will find these so-called incidental findings, so findings that are not related to the primary indication of testing. The disadvantage, on the other hand, is that when you want to update such a panel with newly discovered CATGUT genes, then this really requires a redesign of the panel and validation of the assay. And that's why mostly now, many of us in the diagnostic labs use the so-called targeted exome sequencing or virtual gene panels. So in this case, the full exome, so the 21 genes are sequenced, but only the CATGUT relevant genes are then analyzed and interpreted with these very nice bioinformatic tools. The advantage of such a virtual gene panel is that it's very easy to update the new genes to such a panel. So it requires almost no design and validation. And the other nice thing is that if you do not find anything, then you have the possibility to open up the exome backbone data and then look beyond the known CATGUT genes. So try to find novel candidate genes for CATGUT. And this, of course, then also means that there is a chance that you find something that you were not looking for, so the incidental findings. Genome sequencing is still not very frequently used in diagnostic testing, certainly not for CATGUT, but it is expected in years from now, in a few years from now, to replace all other genomic diagnostic methods. But at the time, it's still too costly and it's still too difficult to interpret the data, especially the non-coding data. So here you see such a virtual gene panel that we use for CATGUT in the Netherlands, and here at the UMC Utrecht is actually the expertise center for genomic testing of nephrogenetic genes. And you can see this is a panel of about 100 genes, easily updated because it's a virtual panel. And as I said, it's also important to think about CNV detection in CATGUT. And CNVs are not always easily picked up by these next generation based gene panels or exome sequencing. You need really sophisticated bioinformatic tools to detect those CNVs. But it's honest to say that these bioinformatic tools are now becoming available, and it seems that we will use this more and more in the diagnostic labs, but not yet routinely in all diagnostic labs. And that's why some labs still say, well, if you want a diagnosis of large CNVs, then we offer you microarray-based techniques, such as, for instance, SNP arrays or multi-duplex ligation-dependent probe amplification. So here you see an example where if you ask for a gene panel and you specifically also want copy number analysis, you really have to indicate that on the form. So again, a poll question, and that is the question, I order genetic tests for my CATGUT patients every week, once or twice every month, a few times per year, never, or I would like to order those tests, but I do not have access to an accredited lab. Please give your answers. Could we see the results? Well, it's nice to see that a majority of you does a few times a year, but also that almost 1/5 would like to, but has no access to an accredited lab. Thank you for these answers. Move on to the next slide. So we recognize that not everybody uses genomic diagnostics in daily practice, and there are possible reasons for this slow implementation. First of all, and that is also much mentioned by adult nephrologists, that there is doubts about what is actually the diagnostic value. Another reason might be, well, what if we detect variants of unknown significance? What do we do with those? Or what if we find incidentals? What do we do with those? There could be also financial issues or logical impracticalities. And as said, especially adult nephrologists are not all accustomed to using genetic tests as a diagnostic approach or modality in their daily practice. So I strongly believe that it is actually very useful to do genome diagnostics in daily practice. But my question to you would be, do you also think that it is useful? And if so, would you think it's useful for diagnostic confirmation, for management, or for the orientation of extrarenal manifestations, or all three? Or do you think, well, I don't think there is any value in testing? Please answer that. Can we see the results? Well, most of you think it's useful for all three. Very nice. And 4%, so there's probably one person, I don't know exactly, say, well, I don't think this is useful. So let's have a look at the possible benefits of testing. Again, I think that if you would use genetics as a first approach in diagnosis of certain CATGUT patients, it could prevent other invasive diagnostic procedures. So it's very nice for a patient only to have a blood test. It is sometimes also useful for CATGUT because an exact diagnosis can be important for management. For instance, in children with hyperdysplasia, we know that it's important to have a strict blood pressure control to slow down the chronic kidney disease in these children. And there are other nice examples of importance for management. It is indeed helpful for orientation of extrarenal manifestations and specific follow-up of these manifestations. For instance, we know when the patient has an HNF1B pathogenic variant, it's important to monitor for diabetes, and patients with PAX2 pathogenic variants should be go to the ophthalmologist to see whether there's an ocular defect, because there is a risk of retinal detachment. A diagnosis can also be very useful in the light of living-related kidney transplantation. Of course, you don't want to use a transplant of a patient who also, of a person who also has a familiar pathogenic variant, and it's important for, of course, for genetic counseling and family planning. An important question indeed is, what is actually the diagnostic value of using genetic testing? And there are not yet really examples of studies that have really looked into daily practice, let's say the real situation, and look what the actually yield of those screens in daily practice is. But so we have to refer to what is known from studies in, in research cohorts, but nevertheless, they give us a real clear picture when or not to do genetic testing. So I show you some of the examples. So the first study is a study we did a couple of years ago in more than 400 unrelated Caucasian patients, both pediatric and adult patients. There were mainly sporadic cases, hardly any familiar, and we included the full phenotypic spectrum of CATGUT. We had a panel of 208 genes, and we did large CNV analysis only for HNF1 beta, and you can see that the yield is very low. And we only found pathogenic variants in PAX2, HNF1 beta, and 6.5. Another study, more recently, it was in Korean only pediatric patients. They only included severe CATGUT, and you can see 2/3 had extrarenal features. There, they only looked at 60 genes. They included CNV analysis, and you can see that the yield is much higher as in our study. It's 14%. And if you then compare the syndromic versus the isolated CATGUT, you can see a very huge difference. So almost 35% in syndromic versus a little bit more than 3% in non-syndromic. Here, HNF1 beta, PAX2, and AR1 were the most involved genes. A very recent study, also in pediatric patients, and these were Indian patients with a large history of consanguinity in about 1/5. And here they also had the full spectrum, but the majority was vesicoureteral reflux and valves. They included a panel, they used a panel of 31 CATGUT genes and no CNV analysis, and the yield was actually 0. They only find variants of unknown significance. And this I think, very famous study by the French group of a couple of years ago, they did analysis in more than 200 unrelated patients, again, mostly severe cases with both kidneys affected, and/or familial cases and/or syndromic forms, and they excluded the valves. About half of them were severe fetal cases, and they did a panel of 330 genes, including CNVs. And you can see that the yield here is almost 18%. So if we all put this together, then we can recognize what the predictors of high diagnostic yield are. First of all, the presence of extrarenal features, so the syndromic cases, but also the specific CATGUT subtype. We've seen that in severe CATGUT, affecting both renal parenchymas with or without urinary tract defects, have actually a high diagnostic yield, whereas in valves or isolated ureteral phenotypes, actually hardly any monogenic cases are found. Another important predictor is a familial history of the kidney disease or the presence of consanguinity, in which you have a high chance of finding a recessive disorder. So we could conclude from this that there is, of course, no one-size-fits-all approach for CATGUT. We have to consider the potential diagnostic yields beforehand. So with the above-mentioned clinical clues for monogenic CATGUT, we could say, well, we have a high chance of finding anything here, so testing seems appropriate. Of course, sometimes also the costs of the test might be important to consider, but also in some countries the payer situation, and also ethical issues. So if you don't want to find any incidentals, you should not do exome sequencing. So if you put this all together, you could say that in syndromic CATGUT, familial CATGUT, or the presence of consanguinity, and sporadic severe cases with kidney parenchymal defects, it is wise to start with a virtual exome-based CATGUT gene panel. And if this is not available in the diagnostic lab you refer to, you can use a targeted CATGUT gene panel. Sometimes it might also be wise, because this is very cheap, to do a SNP array for CNVs first before you start with the CATGUT panel, especially if in your diagnostic lab there is no ability to do CNV analysis with the use of the CATGUT gene panel. And in cases of valves or isolated urethral phenotypes, there seems no reason to do genetic testing at this moment. It is very important that you do as much as you can your testing in an accredited molecular genetic laboratory. And it's also important that for the interpretation of test results, you do this preferably in a multidisciplinary setting, so with a laboratory specialist, a clinical geneticist, a nephrologist, etc. And for the classification of variants, we use the classification of the American College of Medical Genetics and Genomics with these 5 classes, as you see here. Class 1 clearly not pathogenic, and only class 4 and 5 having a diagnosis because this is likely pathogenic or clearly pathogenic. The most difficult outcome, as mentioned earlier, is actually class 3, the variants of unknown significance. We do not know whether they actually might be pathogenic or actually really benign. And that's the reason why in most hospitals, but not all, it is decided not to disclose these VUSs to patients, but some hospitals do. At least the American College of Medical Genetics and Genomics recommends that these VUSs should not be used in clinical decision making, and that people in the diagnostic labs should do everything to resolve the classification. And you can do this when you have a family with CATGUT by segregation analysis, but sometimes you also need functional studies. And of course, this also depends on what kind of a pathogenic variant you have, what kind of VUS you have identified in which gene, if there is a possibility for functional studies. And we should do data sharing. So try to find other patients with mutations in similar genes and similar VUSs, and of course, the similar phenotype. It's also important to recognize that some of the variants that were previously reported as pathogenic mutations also in CATGUT are now questionable with the new knowledge of large databases, because we simply see these variants too much in normal controls. However, given the non-penetrance we know about in CATGUT, it is really difficult in CATGUT to rule out the causality of some of these variants. It is wise to consult updated clinical variant databases such as the ClinVar database or the Leiden variant database. And it's also important for you to know that there are many initiatives now to do the curation of the data that have been published as being variants involved in kidney diseases. So in ClinGen, there are specific clinical domain groups or expert panels that are helpful in defining the relevance of identified genes and variants for various genetic kidney diseases. In ClinGen, there is not yet a specific working group for CATGUT, but this will probably certainly come. And another very nice tool is the Genomics England panel app, or which is quite similar, the panel app of Australia. And these are crowdsourcing tools to allow gene panels to be shared, viewed, and evaluated by a scientific community, again, to curate the data. And both these panel apps have panels for CATGUT. So if you look at the Genomics England panel app, actually, the reviewers should really look at the data and find evidence whether this is indeed a disease gene for that specific phenotype, whether it's, so this is the green one, like as you can see in this picture, or whether there is not enough evidence, and then it's actually a red stop, or whether there's moderate evidence and there's more necessary to find whether this is indeed either green or red. So you can see that there is indeed for a panel app for a panel for CATGUT, and this is just what you can see then on, if you go to the site, you can see that many reviewers had looked at many genes and classified them either as red or as green. And after this has been done, then of course there will be a evaluation of all the experts, and they will consult with clinical teams to finally decide whether genes are either red or green, or are on the waiting list because they can't be solved at this moment. So my take-home messages are that CATGUT is assumed to have a monogenic towards complex etiology involving genetic, epigenetic, and environmental factors, that a monogenic cause, including copy number variants, is present in about 15% of patients, and that this monogenic CATGUT is characterized by extreme phenotypic variability and reduced penetrance in dominant families. CATGUT patients can certainly benefit from genetic testing because it allows personalized management and follow-up, looking at extra-renal features and also appropriate genetic counseling. The predictors of high diagnostic yield are a syndromic CATGUT, familial CATGUT, or the presence of consanguinity, and the severe sporadic cases with kidney parenchymal defects. So in those cases, we advise to do genetic testing using a exome-based virtual gene panel, and if not available, a targeted CATGUT gene panel. But sometimes it may be cost-effective to start with a SNP microarray to detect pathogenic CNVs. Standard screening is not advised at this moment for cases of valves or isolated urethral phenotypes. And I advise you to always be critical in judging the pathogenicity of identified variants. This is really best done in a multidisciplinary setting. And with that, I'd like to acknowledge all the people that I've been working with on this CATGUT cases, together with Albertine van Utrecht and her team in Utrecht, with the people of my team in Groningen, and of course with ERCnet under the leadership of Frans Schaefer, and with a new consortium in the Netherlands, completely focused on understanding more of the CATGUT, the Art Deco consortium led by Rick Westland from Amsterdam UMC. And I was asked to also mention the next webinars that are upcoming. So still in June 28, there will be an update webinar on Gittelman, the adult view by Tom Nijenhuis. In September the 13th, Danielle Bichet will talk about diabetes insipidus. And in the 4th of October, Francesco Emma will talk about non-cystinotic renal Fanconi syndrome. Thanks very much for your attention, and I'm really happy to take any questions.
Thank you very much indeed. That was a wonderful talk. And to all the listeners, you have the chance to send questions to the question box. Until now, I do not see any questions yet. So maybe I can start with a question. So at your center, how do you do it? Do you have a special genetic outpatients for CATGUT patients? Do you have a special clinic for these patients, or how do you deal with it in daily life?
Yeah, so I think it's best to refer to my previous setting in Utrecht, where I was, of course, for a long time. And there we had a specific nephrogenetics clinic, where the clinical geneticist, together with the pediatric nephrologist and also the adult nephrologists for patients. And of course, this was not specifically for CATGUT only, but for all patients with presumably inherited kidney diseases. But indeed, CATGUT patients were also coming to that clinic, yes.
And think about the proportions between adult and pediatric patients. Do you reckon a change over time, or?
Well, I must say still mostly pediatric cases. This is also the case in the UMC Groningen, although we see that, you know, with more interest of adult nephrologists into the subject, we see now that the number of patients we see, adult patients we see, is really increasing. So there is an increasing awareness among adult nephrologists that also among their CKD patients, there are a lot of patients with nephrogenetic disorders and also with CATGUT, and that it might be worthwhile, again, based on the predictors of high diagnostic yield, to do genetic testing. Yes.
Yeah. There's a question by Albertine, and she asks, do I understand correctly that you also advise against genetic testing in bilateral high-grade reflux?
Well, let's say the sign. I think this is a very important question, and it's also, we don't have specific research cohorts that really help us in this way. Again, you know, the cohorts that included reflux did not show any, hardly any yield in these patients. This, of course, also included many cases with unilateral reflux and not bilateral. So I think it's difficult to ask that question, and the only way to really find out is to just do it in a research setting and see whether these patients indeed have, you know, if there's really very high grade bilateral reflux, there is a chance that we might find something. Yeah.
Right. Then maybe I add another question. You at the beginning you mentioned that there's this discussion about whether PUVs should be considered part of CACUT or not, and I was wondering whether you wanted to share your personal opinion with us, and how do you see it?
Yeah, it's really difficult. Um, um, uh, I think there's still a question whether this, if you look to, let's say, the developmental defect, whether this is similar to what, you know, all the other defects. There's really a nephrogenetic defect, and this is, I think, for valves much more difficult to say. The problem, of course, is that, and again, also, if you look to the genetic testing in valves, it gives you almost nothing. This was also what we saw in our study, which also included a lot of valves, and the yield of testing is really very low. And I think there are also not many cases where you find familial cases of urethral valves. Again, showing that, you know, maybe the account of really genetic factors involved in the etiology is for valves much lower than for the rest. But again, no proof. So I find it really difficult, Max, to answer that question. Again, people differently do this in literature, and actually at the moment I'm together with Adrian Wolf, I'm writing a pro and con debate for using CACUT as a term in the future. And Adrian says we should really leave the term CACUT and we only mention the separate phenotypes. And this will also resolve the question whether or not urethral valves belong to CACUT or not. And I write a paper where I think that it's still useful to remain considering these anomalies as a group of anomalies because of the shared etiology. And so
Right.
the future will tell. Adrian said, well, if we leave CACUT, then I can finally sleep again at night. So he was really very, very keen to have us all leave the term CACUT and go to the different. I have a different opinion. Yeah.
Right. And you had a wonderful discussion, that a really high class discussion at ESPN in Amsterdam about it. It was a great pleasure to watch it. There's one question, and I understand it is it's about adult patients. Is there a special time to evaluate genetic testing in adult patients with CACUT? Yes, I understand it may refer to the age of patients, maybe.
Yeah, well, again, it's I also don't really think what the background of that question is, but I think you know, if you know that a patient has CACUT and has not been screened previously in the pediatric situation, of course, then there is, if you find these, again, have these predictors of high diagnostic yield, it should be wise to do it. But we also know that in patients with CKD of unknown origin, it's wise to do genetic testing, and then sometimes the CACUT gene comes out. So I think there's not a special time when you could do it. But if you have either a high suspicion of something genetic, either because it's CACUT or because it's CKD, you don't understand, then I would actually advise to do a genetic test. Yeah.
Right, and there was the wonderful work by Albertine also showing the NPH variants in the CKD in adults of unknown.
Yeah, very surprising to us also that that there is almost 1% of adults even above the age of 60 that can still present with nephronophthisis. So we didn't know that, of course. So
Yeah,
I think that's also an important message that genetic testing will give you also new insights into causes of diseases and that you have never thought of before. So
yeah,
again, we should not be hesitant to do genetic testing when we think it's useful.
right.
And of course, this.
So
Yeah. Sorry.
Adrian is commenting that he doesn't like the term CATGUT, but he did like your lecture, Nina.
Thank you, Adrian. So
Right.
already published his paper, but my reviewers were actually in the paper were saying, well, actually they were in favor of the arguments of Professor Wolf, and actually, so they said to me, why is it like this and that, and of course this is what Adrian said in his lecture, and I was not supposed to do that, so to please them, but it
So it's
was
still open for debate.
yeah,
Right. I don't see another question right now, so maybe I for me, your opinion. You mentioned whole genome, and Adrian adds that he didn't review your paper. He
no,
was not the review. So you mentioned whole genome sequencing coming up.
yeah.
What would be your gut feeling, just a rough estimation for us as clinicians? When roughly are we going to see it in let's say daily clinical work?
Yeah, well, it's a very difficult estimate, Max, to be honest.
Yeah.
So in my lab, we are now because let's say the old-fashioned whole genome sequencing was, of course, with short reads, and
Mm,
that's really, if we really want to find novel variants, and also, things like if we want to include PKD with all of these, difficult sequencing issues, then we actually should directly, if we want to use this in clinics, should go to long read sequencing. So whole genome long read sequencing. And I think every lab is now busy to develop that and make it available for clinical setting. And we are at the moment doing that. We have nice results, and so I think, if this goes on like that, we would be able to have it into a diagnostic fashion in, let's say, 1 or 2 years. But then the
mm,
problem comes: is this still is it not still too costly? And
mhm,
are insurance companies, because in the Netherlands genome diagnostics is insured in healthcare insurance, but are they willing to pay a higher price, because it still is higher, and that's not the, let's say, that's not the laboratory work that's so invasive, but it's especially the bioinformatic tools, the bioinformaticians, and the time that is needed to do the analysis that makes actually the price. So, and that is simply still taking a lot of time. So I think technically it would be possible, but if we can do it for relatively low costs within a very short time, I'm not sure.
right.
So
And
um,
it also takes the brain of a lot of trained people
absolutely,
to get it all
absolutely.
done.
Yep.
Right.
Yeah.
Right. So there's one last question about a specific patient. Maybe I would suggest that for such a question, I'm sure someone can get in touch for you
Yes.
to you directly and
That's
ask for advice. I don't see any additional questions right now. So thanks again, Nina. This was really a wonderful talk and a great discussion, great fun. Um, and so I can invite everyone to come up and join the next session, the next webinars. as already announced by Nina. And thank you very much all for joining this afternoon, and have a good day.
Thank you, Max.
Thank you.